expiratory pressure, positive end expiratory pressure, which is the amount of pressure left inside the lungs at the end of exhalation. The amount of pressure left inside the lungs at the end of exhalation. So that means that you exhale out completely, but you still have some pressure left inside your lungs. Indications and therapeutic objectives of peak therapy. Let's look at those. Number one is that PEEP is used to improve oxygenation at value 2 that is value 2 greater than 60%. So, anytime somebody is on the ventilator and they're having oxygenation problem, initially we will keep on going up on the FiO2 to improve their oxygenation status. And then once we get to 60%, we're going to stop there and check on their PaO2. If their PaO2 is still abnormal or it's not where we want it to be, then we have to assume that the patient has shunts. We're going to give them PEEP. Open up their airways. So if you increase the surface area for gas diffusion, more oxygen will diffuse across the AC membrane into the blood. Okay? Number two, PEEP decreases PIP. Now, PIP is peak inspiratory pressure, the highest pressure that is used to deliver a breath. When the ventilator cycles on, at the end of inspiration, you look on it, on the screen you get your PIP. It's the amount of pressure that you inspired. So now let's look at this here. Now let's say that my lung units are this way, and then I have another lung unit that is that way. So this one has a PEEP of 5. That's what is keeping it open. This one has no PEEP. That's how come it's kind of like collapsed there. So if my lung units are this way, and I'm breathing in from the ventilator, it will take me lesser pressure to completely open it up like that, because it is already opened up to some extent. So I wouldn't have to inhale more pressure to open it up, completely open it up. Compared to this lung unit here, that is not even opened up to any extent at all. I would have to inhale more pressure to completely open it up. So a lung unit that is opened up to some extent will take lesser pressure to completely inflate than a lung unit that has not been opened up at all. So if you give somebody PEEP on the ventilator, you are decreasing the amount of pressure that they need to inspire, because their lung unit would already be opened up to some extent. Does that make sense? Yeah. It decreases PIP. Yeah, if somebody anytime somebody goes on the ventilator, they're going to have some kind of PEEP. Unless they have a disease condition that, that will make them not to use PEEP. Okay? We're always given like at least a PEEP of 5, which is natural PEEP. Now that's another thing too. We have natural PEEP. Our natural PEEP is 5. Everybody has a PEEP of 5 inside their lungs. That's how come your lung units do not completely collapse at the end of exhalation. Even Joe Biden has a PEEP of 5. Joe Biden has a PEEP of 5. He's walking around with it. All right, so PEEP increases non-compliance. PEEP increases lung compliance. The alveoli are distensible. It's like a rubber band. The air comes in, they will inflate like that, stretch. When it goes away, they will collapse back like that. So now, for instance, if you took like a rubber band, right, and you're doing this to it, right? Initially, when you start doing this to it, it's going to be a little harder to stretch it. But now, as time goes on, the compliance improves. You don't have to put a whole lot of pressure to do this. That's the same thing going on inside the lungs. If you apply PEEP inside somebody's lung, it's constantly pushing on their alveoli like that. Okay, over a period of time, you find out that their lungs now will be very easy to open up. So PEEP improves compliance. Anytime somebody has low static compliance, they have low static compliance, you give them PEEP. Okay? You give them PEEP. We can use PEEP edema. Any kind of fluid problem, PEEP is good for. A patient has just gone into pulmonary edema. In order to improve the patient's lung compliance, what would the respiratory therapists do? You increase the PEEP. They have CHF that is causing pulmonary edema. What would you do? You give them PEEP. Now, PEEP is positive pressure, just like BiPAP, CPAP. CPAP equals PEEP. Okay? Studies have shown that positive pressure enhances the absorption of fluid into the lung interstitium. Please check out my English here. How does it sound? Pretty good? All right? That's a good English, right? Studies have shown that PEEP enhances the absorption of fluid into the lung interstitium. Now, positive pressure will force the fluid into the lung tissues. That's how come, they have CHF, we put them on BiPAP. They have pulmonary edema, we put them on BiPAP. Any kind of PAP is good for fluid problem. Flare chest. I think it's like that. The eyes first, okay, well. Flare chest. Yeah, this is where you have two or more ribs broken on one side of your chest, flare chest, as a result of trauma, maybe. And then you may have also contusions with it. Contusions are like internal injury. So what happens with flare chest is that usually when we breathe in, the ribs gives us mechanical advantage. When you breathe in, what happens is that your diaphragm goes down, your rib cage moves outwards. That's what causes you to get in and out of the line, because you create more negative pressure. But now you have two ribs broken on one side, so when you get ready to breathe in, instead of that area of the chest going outwards, it is sinking in. We'll call that paradoxical ventilation. You have paradoxical ventilation when you have flare chest. That area of the chest will sink in instead of going outwards to give you mechanical advantage. PEEP is very good for that. If you give somebody who has flare chest PEEP, that will rigidify that area of the chest. So it is very, very indicated for that. All right, so what am I missing? I think I may be missing one. Electrosis. Okay? PEEP is good for that. You have electrosis on the ventilator, you give them PEEP. Because electrosis causes a decrease in lung compliance. So we gotta give them PEEP. Any questions about the objectives of PEEP therapy? Now remember now that PEEP is the same thing with CPAP. PEEP is the same thing with the EPAP. With the BAPAP, we'll call the PEEP EPAP. These people with positive airway pressure. If you are not on the ventilator, we'll call it CPAP. If you are on the ventilator but you are breathing on your own on a spontaneous mode, we'll call it CPAP. But if you're on the ventilator, you are not breathing on your own, we'll call it PEEP. So a PEEP of 5 equals CPAP of 5 equals EPAP of 5. Make no mistake about that. The indications, the complications, the contraindications for PEEP, CPAP, and EPAP are all the same. Okay? All right, so now let's look at some of the complications of PEEP. It is a positive pressure. A positive pressure is a pressure level that is greater than ambient pressure. Now, the ambient pressure is 760. So this is how we derived PEEP. In respiratory therapy, we assign the barometric value, barometric pressure, which is the ambient pressure. In respiratory therapy, we assign it a value of 0. We know it's 760. Just to make it easier to say and sound good, we assign it 0. So when I say that somebody has a PEEP of 5, what I'm actually saying is that their pressure is 765. 5 points above 760 or 5 points greater than 0. Because we're assuming that 760 is 0. So if you say that PEEP of 5, PEEP of 10, actually you're talking about a pressure of 770. So a positive pressure is a pressure level that is greater than ambient pressure. A negative pressure is a pressure level that is below ambient pressure, less than 760. Okay? So complications of PEEP. Let's go to barotrauma. Barotrauma is the rupture of a lung unit, the rupture of a lung unit due to pressure, due to excessive pressure. Well, PEEP is pressure. You know, if you give somebody too much PEEP, you can pop their lung, one of the lung units open. Okay? We can have pneumothorax. Pneumothorax usually occur as a result of the barotrauma. The lung unit ruptures and then the air begins to leak out and leaks into the pleural space. That's pneumothorax. Hypotension. Now, hypertension is low blood pressure. People will cause your blood pressure to drop. So when we get to complications of mechanical ventilation, you're going to find out that PEEP decreases venous return. It makes it very difficult for blood to return back to the right side of the heart. As a result of that, their blood pressure goes down. So, if you're taking care of your patient on the ventilator and they're having blood pressure problems, their blood pressure is very low, well, adding PEEP will make it worse. So you will be better off using FiO2. That will be one of the times that you may use FiO2 that is greater than 60 without adding PEEP. Okay? So hypertension. And then we have increased ICP, intracranial pressure, the amount of pressure inside the skull. Normal is 5 to 10. 5 to 10 millimeters of mercury is normal pressure in there. Too much PEEP causes venous return to decrease from the upper portion of the body. Blood returning from the head down into the heart through the superior vena cava will kind of like back up. It backs up into the skull. Well, the skull is a very rigid structure. It doesn't expand with the increase in volume. So the pressure there goes through the roof. So people can do that. So normal ICP, 5 to 10 millimeters of mercury, 20 or less is acceptable. So in essence, when somebody has ICP of 20 or less clinically, they don't really worry so much about it. It's when it's greater than 20. Dead space, increase in dead space. People can cause dead space problems. Dead space problems. Now let's look at the pulmonary artery here. Here's my 4-chamber something called. Here's my right ventricle. Here's my pulmonary artery. Like that. Now, if you give somebody too much PEEP, that can compress the pulmonary artery. And you squeeze it. How do we define dead space? Dead space is ventilation in excess of perfusion. That's dead space. So now, if this is squeezed, meaning that the diameter will decrease like that, blood flow to it will decrease. So you're decreasing perfusion. So ventilation in excess of perfusion. So too much PEEP will cause dead space. And here's another way to look at it. Let's say that I have a long unit like this, and then here are my pulmonary capillaries right here. Pulmonary capillaries. And let's say I have a PEEP of 5 in here. Now, the pulmonary capillaries perfuse the alveoli. That's what they do. Now, I'm giving my patient a PEEP of 20. Do you think because I had a PEEP of 20 and causes him to get this big, somehow God is going to make me some more pulmonary capillary? No. God is not going to give me any more pulmonary capillary. It's the same pulmonary capillary will now try to perfuse all this area. So we're going to have a decrease in perfusion, which will be dead space. Dead space is not good. Dead space will mess up your ventilation. If your dead space goes up, your CO2 goes up. So we always have to be on the lookout for that. Okay? What else? This should do for right now. Okay? Now, contraindications of PEEP therapy. The reason why you wouldn't want to give somebody PEEP. Now, there is something called absolute contraindication. And then there's another thing called relative contraindication. Relative contraindication means that you can do it, but you have to be very careful, right? Absolute contraindication means no way you can do it. So, one of the absolute contraindications for PEEP, the one that I really want you to remember is tension pneumothorax. Tension pneumo. Let's make it untreated tension pneumo. How do we treat tension pneumothorax?
Needle decompression.
Very good. Needle aspiration or chest decompression. That's the air inside the pleural space is under pressure. As a result of that, the lungs are getting compressed. If the lungs are getting compressed, your ventilation is not good. Your oxygenation is not good. So we'll do that needle compression. We'll let the pressure off the chest so that the lungs can re-expand. So if you know that somebody has untreated tension pneumothorax, you can't give them PEEP. That will make it worse. Severe hypotension. Severe hypertension, their blood pressure is very, very low. You don't want to try it. If your patient is having an oxygenation problem, you're better off using 100% FiO2 or anything up there. You can go all the way to 100%. I want you to understand what that rule says. It doesn't say that you cannot use any FiO2 that is greater than 60%. It's not what it's saying. What it's saying is that you are better off using positive pressure after you've gotten up to 60% and the patient is not oxygenated. you're better off using positive pressure because that can save the patient complications associated with a high FiO2. But if you must use it, you can use it. And this is one of the instances. Somebody has low blood pressure, but their oxygenation is bad too. Well, I can give them PEEP, so I use whatever FiO2 that I need. I just have to worry about the complications of using the FiO2. So these are the two absolute contraindications. You can't add PEEP. Now, we have other things, like relative contraindication. We have bleb. Bleb is like a herniated alveoli. It is very popular with emphysema. Emphysema patients have bleb. A lung unit that has been distended to some extent that a little additional pressure will cause it to pop open. So when you are treating a patient with emphysema and they have bullous emphysema, you gotta be careful. It's not like you can't use PEEP, but you keep that in mind. So, well, I have to keep my eyes on this. It's a relative contraindication. Low blood pressure that is not very severe is relative contraindication. ICP, relative contraindication, even if it is like 25, you can say, well, yeah, it's high, but I have to keep my eyes on it since the patient needs PEEP. Any questions about contraindications of PEEP? Like dead space is another relative contraindication. Just like somebody has increased dead space doesn't mean that they can't have PEEP, but you have to keep in mind that the more PEEP you add, the more dead space that they're going to have. Okay? All right, let's move on here. Okay, so here's item, what we call this respiratory pattern. That's what we call this story here. Respiratory pattern. The I time, the expiratory time, the total cycle time. Again, I time is the amount of time it takes you to breathe in. Normal I time is usually 0.8 seconds to 1 second. That's usually about what normal I time is for everybody. Sometimes it can be a little higher, or a little lower. E time is always like twice your I time. Sometimes it can be more than that, especially if you're dealing with a COPD patient. Anytime we're evaluating COPD patients, we want to give them ITE ratio that is larger. We want to give them more time to exhale out so that they don't get trapped. Okay? So E time will be at least, physiologically, at least twice higher than your I time. 1 to 2 ITE ratio. Total cycle time is the amount of time that it takes you to breathe in plus breathe out. Combined, I time and E time. So this is the formula that I was working earlier. So we're going to go in a full scale with it. I want you to memorize that formula. I time equals tidal volume in liters divided by flow in liters per second. And I can rewrite that formula in 3 different ways. All right, in 2 different ways. So I can go I time equals tidal volume in liter divided by flow in liters per second. And then I can go flow, if I'm looking for my flow equals tidal volume divided by I time or I can go, which one I am missing? Flow, tidal volume, tidal volume equals flow times I time. The same formula. So they go, well, you know, a patient has a tidal volume of this and the flow of this, what's the high time? You got it right there, the first one. Well, they have tidal volume of this and the high time is what's their flow? It's the same thing, you just have to change it around. The same thing with the tidal volume there. Okay? So, the total cycle time you calculate by dividing your respiratory rate into 60. You divide 60 by your respiratory rate because you have 60 seconds in 1 minute. The respiratory rate is based on 1 minute. So that's why we got that 60 from. And again, I want you to know that since the total cycle time is the sum of your I time and your E time, we can then express it this way. We can say that TCT equals I time plus E time. Well, really, that way, we're saying the same thing. So you know that, and then our TCT equals 60 divided by respiratory rate. These are two ways to calculate TCT. Any questions about that? So that second one there is your E time. So if I know what my TCT is, which is the sum of my I time and the E time, and then I happen to know what my I time is, well, I can find out what my E time is, because I can just take my I time away from my total cycle time, and then what will be left will be my E time. Okay? All right, so let's do some examples here. Do I have some examples here? No, not. Let's do some example here. Okay, so my patient is on a tidal volume of 500 milliliter. We have a flow rate of, I want to say, 30 liters per minute. We have respiratory rate of 15. I want to calculate my I time. You're going to have this on your quiz. Calculate my I time, my total cycle time, my E time, and my IDE ratio. Let me see if I have IDE ratio here. Yeah, okay. Now, let me talk about IDE ratio. The IDE ratio means by how much is your E time greater than your I time. That's all it is. By how much is your E time greater than your I time, or by how much is your I time smaller than your E time. So if I have IDE ratio of 1 to 4, what it tells me is that my E time is 4 times greater than my I time. This is not the I time, this is not the E time. This is the I ratio, this is the E ratio. Well, I can say that my I time is 4 times smaller than my E time. That's what your IDE ratio tells you. Okay? All right, so now let's move on here. So the first thing there is for me to calculate I time. So I'm going to always write down your formula first. I go I time equals tidal volume in liter milliliter divided by flow in liter per second. Okay, so now, my tidal volume is 500 milliliters. Well, the formula calls for me to convert that to liter. So I have to divide by 1,000. So that will give me 0.5 there. And then my flow is given in liters per minute. That's a standard unit of flow. But the formula now calls for me to convert it to liters per second. So I have to divide the 30 by 60. So again, that would be 0.5, right? So 0.5 divided by 0.5 is 1. So my I time equals 1 second, 1.0 second. And that's the amount of time it takes me to put in. And then the next thing now is that I want to calculate my total cycle time because I know what my respiratory rate is. So it'll be TCT equals 60 seconds in 1 minute divided by respiratory rate, which will be equal to 60 divided by 15, which is 4 seconds. So now, it's taking me 4 seconds to breathe in and breathe out. And it's taking me 1 second to breathe in. So I can find out how long it takes me to breathe out. So I'm going to subtract my I time from my total cycle time on that second one. So it'll be E time equals TCT minus I time, which will be 4 minus 1 equals 3. If you add your I time and your E time together, they must be equal to your total cycle time. If not, then you don't have it right. They should check out. So 3 plus 1 equals 4. And then add E ratio, okay? You're gonna do add E ratio equals I time divided by I time to E time divided by I time. Now, I want to tell you this here. You don't always divide by the I time. You divide by whichever one that is smaller between the two. Because the reason I'm saying that is that on the exam, they may have you calculating inverse I to E ratio, where the I time will be longer than the E time. So always, once you get it, whichever one that is smaller is what you divide by. Like now, my I time is smaller than my E time, so I have to divide both of them by my I time. If my E time was smaller than my I time, then I'll be dividing both of them by my E time. I want you to remember the way that. So now, I'm going to go, my I time is 1 second, divided by I time 1 second equals, E time is 3, right? Divided by 1. So what I have is 1, 2, 3. What does that mean? It means that my E time is 3 times greater than my I time. This is not my E time. It just happens to be the same thing in this case. It's not always that way. But that's what it means. My E time is 3 times greater than my I time. Any questions about that? All right, so let me give you one to do, and then we'll move forward and calculate another type of this question here. Okay, so a patient has a tidal volume of 700 milliliter. flow rate. No, yeah, make it 750. 750 tidal volume. A flow rate of 45 liters per minute. And a respiratory rate of 12. Calculate the I time, the total cycle time, the E time, and the IDE ratio. So let me see, I say tidal volume 750 milliliter. Respiratory rate, I think I said 12 breaths per minute. Flow is 45 liters per minute. So calculate the I time, the total cycle time, the E time, and the IDE ratio. You're gonna have this on your quiz. Let me know if you need some help. Anything, Ray? Okay. What I'm checking it out is you take your E ratio, which is 4, you multiply that by your I time, and see if you get your E time. That's another way to check it out. You get 4 times your I time, then that should be equal to your E time.
I didn't write it down, but I did finish it. I didn't write it down, but I
Okay.
did finish it.
Okay. You get it, Ashley? Okay, very good. How about you, Cassandra? Okay, very good, very good, we're doing good. And here's Kathy, right? Does anyone have any question before we move forward here? You should have gotten IDE ratio of 1 to 4. And then that will make everything else right. Okay, now look at this tab here. The patient on the ventilator has IDE ratio of 1 to 4. That's their IDE ratio on the ventilator. The patient's I time is 0.75 seconds. What is the patient's respiratory rate on the ventilator? We have IDE ratio of 1 to 4, and we have I time of 0.75 seconds. What is the patient's rate on the ventilator? Okay, so the way we can do that, we can remember that total cycle time equals I time plus E time. So my I time is 0.75. How do I get my E time? So I can get my total cycle time? Well, the only way I can get it is that if I look at my IDE ratio, the ratio tells me that my E time is 4 times greater than my I time. So in order to get that E time, then I have to multiply my I time by my E ratio. So 4 times 7.5 will be what? That will be
3.
eh?
3.
3? Okay. So my E time is 30 seconds. So I can add it together now. So my TCT equals 3.75 seconds. That's my total cycle time. And then I have another formula that says that total cycle time equals 60 seconds in 1 minute divided by 10. Where did I know? I already know. I know now what my total cycle time is. So I put it right here, 30.75 equals 60. I'm looking for my respiratory rate now. I can cross multiply, so I'll get 3.75 RR equals 60. And then you divide both sides by 3.75. So if I divide this side here by 3.75, it will cancel this here. And then I divide 60 by 3.75. What's 60 divided by 3.75? A little bit above 14 maybe?
16.
15?
16.
15, yeah. So my respiratory rate is 15 on the ventilator. You understand that? All right, let's do an example of this and then we'll do one more, different one. Okay, so the patient on the ventilator has I time of, I time of, I want to make it come out even there. There's the I time of 1 on the ventilator. And the ITE ratio is 1 to 5. What is the patient's ventilator rate? See if you can get that. They have I time of 1 second and E time of, excuse me, an ITE ratio of 1 to 5. So ITE ratio equals 1 to 5 and I time equals 1 second. What is the ventilator rate? Do it like we did the last one. Let me know if you have any question. What you got?
I got 10.
Hmm?
10.
Okay. You need a minute? Okay. So, so this means that your B time is 5 times greater than the I time. So the I time is 1, so we multiply by 5. So that's why it's 1 plus 1. And then you add it together into the patient's lungs, not all of it. There's something called tubing compliance. I don't know whether you went over that. Some of that volume that is going to come out from the ventilator may stay inside the ventilator circuit and never make it down into the patient's lungs. So they don't count. Whatever is inside the circuit will not count. So what will count is what came out from the patient's lungs, which would be the exhaled tidal volume. That's what impacted the patient tidal volume. I mean, the patient lung compliance and ventilation. Okay? So because, there is gas flow coming in when we're measuring the dynamic compliance best reflects airway resistance. Dynamic compliance reflects airway resistance. When dynamic compliance is decreasing, airway resistance is increasing. This is a very common question on the test, MUSC test. You gotta know it. When dynamic compliance is decreasing, airway resistance is increasing. That's the way you're gonna do that. Now, here's an example. Let's say that a respiratory therapist calculated the dynamic compliance at 8 o'clock. And you got 40 milliliter per centimeter of water. Basically, what that means is that for every 1 unit of pressure that you're putting into that patient's lungs, you are getting 40 milliliters of water. That's what it means. The more volume that you can get in per unit of pressure, the better your lung compliance will be. So this is what I calculated at 8 o'clock. Then I came back at 12 o'clock to do another vent check, and I calculated my dynamic compliance. Now I have 20 milliliter per centimeter of water. It's gone down. Here I was getting 40 milliliter per unit of pressure. Here now I'm getting 20. So my dynamic compliance has decreased. What would I attribute that to? It's due to increasing airway resistance. So it's like this. Instead I have secretions here. And the volume is coming in. Because of the resistance here, I didn't get enough volume here. And the volume comes out, and then we divide it by PRP minus P. So when dynamic compliance is decreasing, your airway resistance is increasing. When dynamic compliance is increasing, it goes from 20 to 40, airway resistance is decreasing. So one way that they ask that on the test is that a patient's dynamic compliance has decreased, which of the following would the respiratory therapist not think is the problem? Well, so what that means, you got to troubleshoot for everything that can cause increase in airway resistance. Bronchospasms, would that cause increase in airway resistance? Yeah. Yeah, bronchospasms can cause it. And now if I know that it's bronchospasms, and you say, well, what would you do about it? Well, I'm going to give them a Albuterol. I'll give them a breathing treatment. That will eliminate the airway resistance, and then my volume should come back up. Well, will secretions cause it? Yeah, accumulated secretions will cause it. If I know that that is the case, well, I can suction them out. And that will fix it. How about kinked airway? Like that. Patient does their neck like that. The ET tube is kinked. That will cause it too. How about water in the ventilator circuit? Remember now, the flow has to come out from the ventilator, go to that tubing to make it down into the patient's lungs. That water will be in the way. Resistance is obstruction to flow, period. Resistance is obstruction to flow. If you don't have any flow, you don't have any resistance, because it is just obstruction to flow. So, from now moving forward, that's what I want you to relate dynamic compliance to, because it is always on the test. Okay? If they say compliance, dynamic compliance is going up, you say airway resistance is decreasing. If they say dynamic compliance is decreasing, you say airway resistance is increasing. Period. Now, the next one is static compliance. It is the compliance of the lungs measured when there is no gas flow. Because when you do that, it's plateau minus PEEP. When you do inspiratory pause, you pause the patient's inspiration. There's no more flow coming in. At that point, the pressure inside the lungs is nothing but the plateau pressure. That's the pressure that you used to expand the patient's lungs. So static compliance reflects lung compliance. If you really want to know how stiff a patient's lungs are, you look at your static compliance, not your dynamic compliance. You look at your static compliance. If your static compliance is bad, is low, abnormally low, you give them PEEP, because that would mean that their lungs are very stiff. Okay? So now, if my static compliance is decreasing, goes from 40, I was getting 40 milliliter per centimeter of water, now it's 20. The way I'm going to interpret that is that my lung compliance is decreasing. My lung compliance is decreasing. If it's going the other way, from 20 to 40, that would mean that my lung compliance is increasing. If your lungs are easier to stretch, well, the more volume that you will be able to get in. It's very simple. Any questions? So it's not just knowing how to calculate this. You need to know what they mean. Okay, you need to know what they mean, what the numbers mean. Factors affecting lung compliance, we have alveolar surface forces, surface tension, and we have the fibers, the amount of fibers inside your lungs. Elastance. Elastance is the opposite of compliance. Compliance is the ability of the lung unit to stretch. Elastance is the ability of the lung unit to rebound. They have an inverse relationship. If your compliance is high, your elastance will be low. If your compliance is low, your rebounding, your compliance will be, elastance will be high. For instance, a COPD patient will have high lung compliance because they don't have as much fibers. Remember, the emphysema, the cigarette smoke, destroys all the fibers. So they have high compliance but low elasticity. That's how come they do a lot of air trapping. The rebounding is what part of what determines your expiratory time. Whether air is going to go away very quickly from your lungs. COPD patients don't have that. Now you take somebody that has ARDS, adult respiratory distress syndrome, their lungs are very stiff. So it takes fractions of seconds to fill it up because it can't expand. And then when they rebound, they go like that. That's how come we use a lot of PEEP. We use a lot of PEEP when we ventilate patients that have ARDS. Okay? Resistance. Now, resistance is obstruction to flow. Obstruction to flow. Now, if I'm going to come inside this classroom and you guys are standing at the door, well, I can't get in. That's resistance. Right? That's resistance. I can't come in. But now, if you guys are not standing there, well, I can come in. I don't have any resistance. So if you don't have any flow, you don't have any resistance because it is just obstructing to flow. Okay? Here are the factors that may affect resistance. Viscosity of the gas, how thick the gas is. We're talking about oxygen and air. Those are mainly the two gases that we use during mechanical ventilation. How thick are they? Okay? Viscosity is the ability of gas or fluid to flow. A liquid or gas that can easily flow has low viscosity. A liquid or gas that is very difficult to flow has high viscosity. So we want to know how thick the oxygen is or how thick the air is because that affects the flow into the patient's lungs. So it can affect it. Length of the airway is another thing. The longer the airway, the higher the resistance. A patient intubated with ET tube will have higher airway resistance compared to somebody who is straight. Because tracheostomy tube is shorter than the ET tube, right? So the longer the airway, the higher the resistance. The shorter the airway, the shorter the resistance. One thing that we get is that sometimes a patient is weaning from the ventilator and they're proven to be very difficult to be weaned. The doctor may decide to trach the patient because once you trach the patient, the airway is smaller and the patient will wean quicker. You decrease airway resistance and then decrease their space. And then that causes them to wean faster. Diameter of the airway, that's the one that respiratory therapists have control over. That we can control that. Because now here's the ET tube. A lot of things can cause that diameter to change, and respiratory therapists can fix it. Those are clinical factors. Secretions can cause it. We remove the secretions, kink the airway, we remove it. Water in there, we remove it. Edema, whatever, we remove it. Okay, we have control over that. That's what we call those clinical factors. Now, we can't do anything about the viscosity, but we already know how thick the oxygen is. We already know how thick the air is. So all of that is already into the equation. So we don't worry about that. Length of the airway, well, it's either going to be ET tube or tracheostomy tube. It's already into the equation. So we don't really worry that much about that unless we're trying to wean the patient and the patient is not winning. So the only thing that we are really worried about is the clinical factors. The accumulated secretions, obstruction in it, edema there, bronchospasms, that kind of stuff. And we can fix every one of them like I told you. If it is edema, we're going to give them steroids. We'll fix it. If it is secretions, we're going to suction them out. If it is bronchospasm, we're going to give them a breathing treatment. Every one of them will have the capability of fixing. Normal resistance. In somebody that is not a mechanical ventilation, it is 2.4, no, wait a minute, 0.6 to 2.4 centimeter of water per liter per second. 0.6 to 2.4, that's what your textbook says. 0.6 to 2.4 centimeter of water per liter per second. That's normal airway resistance. But now, if a patient is intubated, that is different because the diameter of the ET tube is way smaller than the diameter of the trachea. Remember, when anytime diameter decreases, pressure goes up. So if you're intubated, normal airway resistance will be 5 to 7 centimeter of water per liter per second, just because of the diameter of the ET tube. But now, if I have it more than 7 and somebody is intubated, I will have a problem with that. That will be very high. And also remember that the bigger the ET tube, the smaller the airway resistance. If you want to intubate your patient, the best thing that you can do for that patient is to intubate them with the larger diameter of the ET tube that can go through their glottis. Get in number 8. If you can get it in, that will lower airway resistance. But if you put in like number 6, that's like somebody breathing in through a straw, your PRP will go through the roof. But there are times when we have to use number 6, like somebody has epiglottitis. That's already swelling and occluding the airway. And then you cannot get the number 8 or number 7 past the vocal cords. You have no choice other than using number 6. Like, so there are some times when you have to do that. Okay? Here's the formula here. I'm going to do one very quickly here. It says PIP minus plateau divided by flow in liters per second. Okay, so the patient is on the ventilator with PIP of 20 and plateau pressure of 15 and the flow rate of 30 liters per minute. What's the patient's airway resistance on the ventilator? So I write down my formula, PIP 20, plateau 15, divided by, well, the formula calls for me to convert my flow to liters per second. So I have to divide it 30 by 60. That gives me 0.5 here. That's where most people go wrong on their airway resistance. So what I have is 5 divided by 0.5, which will be 10 centimeters of water 1 liter per second. That's my airway resistance. So by our definition on the ventilator, that would be a high airway resistance. Can everybody do that? I think it's on your quiz. Let's move on here so that we can finish. How many more slides do I have?
You're on 19 out of 25.
7.
Huh?
7.
What?
Yes. That's what it says.
Okay. All right, so what I'm going to do then is, when do we have our quiz? You start the lecture, right?
Quiz is on the 7th.
Okay.
Next Thursday.
Okay. So what I'm gonna do then is I'm gonna stop right here. And on Tuesday, I'm gonna finish it up and start with a new lecture, okay? But just know that